Door.
Okay. Good morning. My name is Lisa Roberts. I am a clinical specialist with Boston Scientific EKOS, and I am going to do an in-service review on the EKOS CU 4.0. It is acoustic pulse thrombolysis used to treat patients with clot anywhere from the neck down except the coronaries, arterial, venous, in a native vessel, in a graft, and about 12 years ago, we were cleared by the FDA to treat pulmonary embolism. We're actually the first device in the U.S. cleared to treat PE. We're the most studied device in the PE world. We did it before it was the cool kids procedure. So that being said, I'm going to go over the technology, go over the equipment, and then do some troubleshooting in case you were to have any problems with the equipment while these patients are being cared for here in PACU. So basically what we know is that when ultrasound is applied to clot, the fibrin mesh within the clot loosens and winds, therefore making more plasminogen receptor sites available. With more receptor sites available, there's a greater chance for uptake of your drugs, and ultimately you're going to end up lysing these patients faster. So how do we do this? Well, it is based off of our mechanism of action. So first, as mentioned, we have fibrin separation. So by exposing clot to a specific frequency of ultrasound, the fibrin mesh thin, it loosens, there's more space. The best analogy I can give you is that it's like taking an ice cube and turning it into a snow cone, so that way the drugs get in and penetrate more rapidly. The other thing we do, we have an active drug delivery system. So using pulse ultrasound, the acoustic streaming, the pulsing coming off the transducers, we actually force the drugs from the catheter through the clot to the walls of the vessel. So there's better coverage of the drug. Better coverage, better penetration. It makes sense we're going to end up lysing these patients faster. Now, they've also figured out that when a catheter is placed in a vessel, the endothelium is encouraged to release nitric oxide. Nitric oxide is a vasodilator, so they are finding post-EKOS procedure that there's greater perfusion, especially down in the lower lobes of the lung and subsegmental branches. So win-win for the patients on that one. Now, we do this with multiple pieces of equipment. We have the control unit, the CIC, catheter interface connector. We use your hospital pumps. We don't bring anything new and fancy. 3 pumps per catheter. One for your drug, which is your TPA. It's going to run anywhere from 0.5 to 2 milligrams per hour. Your flow rate is a minimum of 5 to 35 ml per hour. Your coolant, normal saline, it's going to run at a minimum of 35 ml per hour, can be titrated up to 120 ml if we get a temperature error on the control unit. Sheath management, that is normally a subtherapeutic dose of heparin. It is determined by the physician on a per patient basis. We at Boston Scientific do not dictate that dose. It can be referenced from any of our trials, but most of the time we see anywhere from 300 to 500 units per sheath. And again, that is determined by the physician on a per patient basis. So that's the pumps. And then we have the hooks here for your high alert meds on the front. There's one in the back where we normally hang the coolant. We flip this around. We have a 12-foot cord that goes to our power strip. Flip this back on. And then, of course, we have our catheter. So the catheter is a little different than a regular lytic catheter. Instead of a single lumen with an infusion segment, this catheter actually has 4 lumens. So we have 3 capillary-like drug lumens on the outside of the catheter, and then your coolant lumen, which is your central wire lumen. Now within that central wire lumen, the ultrasonic core is placed. Within the drug lumens, there are thermal sensors that regulate the power to the ultrasonic core. Now, I'm a hands-on kind of a girl. This is our catheter. It is 5.4 French, normally delivers through a minimum of a 6 French sheath. There's 2 different working lengths. This is the 106 version. We also have a 135 length version for patients that are over 6 foot. If we're doing contralateral access to get down into the tibial vessels, or say we're going from the arm or maybe IJ. If there's ever a question about what size has been placed in the body, there's 2 little white labels on the catheter connectors here that you can locate the information. It'll give you the working length and treatment zone. Also, there's a screen on the control unit that I'll show you that when we get to that screen. Now, treatment zone is denoted by proximal and distal markers. The sizes range from a 6 centimeter treatment zone all the way up to a 50 centimeter treatment zone. The infusion holes are laser drilled micropores. They're about half the size of a human hair. They spiral down the infusion segment, so kind of think of this area almost like a soaker hose, then corresponding via the lumen to the port that is labeled and color-coded drug. Drug of choice is TPA, alteplase, used at a physician-specified dose, as mentioned, anywhere from 0.5 to 2 milligrams per hour. The other port, labeled and color-coded coolant, room temperature fluid, normal saline run at a minimum of 35 ml per hour, can be titrated up to 120 as mentioned before. And that is used to cool the ultrasonic core. Now the transducers, even as small as they are, they're about the size of a grain of rice, there's some heat that comes off the catheter. The room temperature fluid combined with the patient's own body fluid, their blood circulating around the catheter, is enough to keep the catheters cool and working efficiently. So the catheters are placed on a 1-to-1 ratio with the clot. If a doctor can get a guide wire through the clot, then they can use this catheter. It's not a drip catheter that you just set in the near vicinity. It actually sits in the middle of the clot. So procedure normally goes as follows. Access is gained with your 6 French sheath. Guide wire is advanced through the clot. Infusion portion is prepped and primed outside the body, advanced over the guide wire is removed, and then the ultrasonic core is advanced into the lumen. Now, essentially the doctors are done with their part of the procedure. It's now up to the techs and nurses to secure the catheters in place and hook up the fluids. So the stopcocks are here so we can make a fluid-to-fluid connection in the cath lab. You never want to draw back on this catheter once it is placed in the body. With the infusion holes being so small, you would effectively clot the catheter off and render it useless. Also, you never want to give any meds other than what's connected to your pumps. You'd be injecting into clot and the medication wouldn't be circulated very well. So forward flush only, never draw back, never give any meds other than what's connected. These are your electrical connectors that hook up to the control unit. I'm going to show you how everything is hooked up and turned on and programmed. But this is basically for troubleshooting purposes, because when you get these patients, everything will be hooked up, turned on, programmed, and running. You're going to be on maintenance mode. It's more about caring for the patient and their needs than it is worrying about the equipment. So the main power switch is down here in the corner. The green light comes on. That just means there's power to the unit. Above that is your mute or your audio pause button, as they like to call it. Dual channel capability. We can run 1 or 2 catheters with this machine. Your start, your stop, channel A, channel B. The heart signifies that this equipment is defibrillator compatible, meaning if your patient is being shocked and you are close to or leaning on it, you will not get shocked. These are the CIC cable connectors. CIC, catheter interface connector. It will light up A or B depending on what channel we're connected to. Light up green when a catheter is connected properly, red when there is a problem. They're stored here on the side when not in use. And when the machine comes up, you are going to be on your home tab. You're going to see 3 colors associated with this tab. Green means everything is good. Red means there's a problem. Yellow means something needs to happen. So right now, both channels say connect. So I am going to take a simulator with the same connectors, black triangle, gray circle, only one way to do this, and we just plug them straight in, lights up green, so now it says it's ready, but we actually have to hit the start button for it to start delivering the ultrasound therapy. So we hit start, it says it's running, it gives us hours, minutes, and seconds on the screen. If we're not using the second channel, the other channel will be deactivated, so there's no information on there. The next tab is our information tab. This is where you can locate the serial numbers for the control unit, CIC, catheter. This is also where you can tell the size of the catheter, just like the labels on the connector. We also have the EKOS helpline number here, it's on the back, it's all over the place. Call us. You get a live person 24 hours a day, 7 days a week in order to help you. It's manned by the clinical staff. I'll be on call on Fridays, so you could get me. Next tab over is our power graph. This is where we document the average total power that's delivered to each catheter. Catheter A is always going to be a straight line, B is always going to be a dotted line. Up in the corner is our battery information. We are at 87% right now. The battery is solid because I am on battery power. If it was plugged in, you would see a little plug. If it's charging, you're going to see a lightning bolt on that plug. When we are on battery power, the power levels actually drop down below 50% to conserve battery life. One catheter will run for 2 hours on a fully charged battery. 2 catheters will run for 1 hour on a fully charged battery. So whenever we transport, get to wherever we're going, we want to make sure it's plugged into a wall socket. We never plug this into a bed because it draws off too much power and will trip the breakers. Last tab is our settings tab. This is where you can adjust volume, screen brightness, and pick a language. So you always want to be on the home tab, and let's just say for whatever reason, turns red, obnoxious noise. So I'm going to hit the mute button here. It says we have a connection error. It documents the runtime, and it gives us our troubleshooting right on the screen. Now at the bottom of the troubleshooting, it gives an E code, the letter E and a number. That E code you'd want to have available if you ever call the helpline, because it helps us follow the proper algorithm to get you guys up and running as quickly as possible. So I'm going to fix this. I'm going to do it again. I'm going to do it a third time. So now it says the same errors occurred 3 times, and we give you the helpline number. It's the 3 strikes you're out scenario. We give you a couple shots, do it on your own, but then we want you to call us. So I'm going to check this. It looks good. We're green. I'm going to hit retry. It says we're good, but your patient calls you, so you step away from the machine. So I say, hey, you forgot to turn me on. You always have to restart the ultrasound after clearing an alarm.
You showed the message again?
Yes, so yeah, so it's gonna tell you, so black triangle, it'll tell you specifically what the connector, if it's a connection error. There are some errors that will come up that will say to call the helpline immediately. So yes, so as soon as I fix it, it's like, okay, please start me. Echo, Doppler, duplex ultrasound, and a bladder scanner. Those exams might experience artifact or interference from the ultrasound that we use, if it's a similar or close to frequency. In those cases, you would hit stop to pause the ultrasound. In 5 minutes, it will beep to remind you to restart. If you need longer, you can hit the stop button again and reset the 5-minute timer. We're only pausing the ultrasound. We're not stopping drug therapy. So technically, it can be stopped as many times as you need to. Like if we're doing an echo, you would caused this. Now, they'll still have the actual artifact from the catheter itself, but just not the ultrasound artifact.
So the ultrasound, is that something that's constant unless you pause it?
Unless you pause it, yeah. And it is actually considered a prescription. So, other than pausing for like diagnostic exams or something like that, you need an order to stop it. So like when we pull the catheters, you have a doctor's order to stop the ultrasound and DC the drugs. Sometimes they'll pull bedside with the PEs. Arterial and DVTs always will come back to the cath lab, but PEs will sometimes be pulled bedside. Doctors or the techs may come up and pull it, and they'll have an order to stop at that point. But yeah, you always want to make sure that it is up and running.
Let me ask you about the tabs.
Sure.
Why would you need 2 tabs? Does it correlate to the number of sheets?
You mean 2 channels?
Yeah.
Yeah.
Are these channels A and B?
Yeah.
Okay.
So you would have catheter A, catheter B.
Okay.
So like
So
if
different
it's a PE, sometimes you'll have a catheter to the left, one to the right. Same thing DVT. Sometimes they'll access popliteal and go up with 2 catheters. If it's a heavily clotted DVT. Other times it may just be one, and then the other channel would be disabled. And then if you're DCing the catheters, you would stop this. These would be disconnected. Catheter would be removed per hospital protocol, and then this is held for 10 seconds. The EKOS screen comes up. When that screen goes dark, the machine is DC'd, and then your pumps are just DC'd per protocol. Any other questions?
I assume leg completely straight.
Wait.
I assume leg completely straight.
Yeah, depending
there's-
on where the access point is. So PEs, they can access IJ also. There's a trend right now, they'll put 2 brachials sheets in and do it that way. Groin, they may stack them on top of each other. If there's like clot in the left leg, they'll stack them both on right. I've seen them put them in both. Let's see, popliteal for DVTs. However we can get to it, just really depends. But it's going to be a minimum of a 6 French sheet. Sometimes contralateral, they may size up and go like 7 to go up and over, to go down into the lower leg.
I think my question was, so whichever side it is, are they not able to move that arm, leg,
Yeah,
or
so
at all?
you would just
Or
really
the-
just evaluate the patient. So if it is like say arterial and you're going up and over, you would immobilize both, because if they bend this leg, it can push the catheter up into the aorta. So you would want to have 2 immobilizers on them. If it's arm, an immobilizer on the arm. Most of the time the immobilizers are applied in the cath lab, so you guys shouldn't have to worry about that. Most of this, like, we had one patient, by the time we got everything done over there, the recovery time was already done, and the patient went straight up to the unit. You guys maybe utilize, if there's no bed available, that kind of a situation.
What unit does the patient go to?
ICU.
ICU.
Yeah,
Only.
if they're, because, I mean, it's they TPA running, so they're gonna go to a critical care bed, so.
You said something about the coolant, and if the system overheats or something,
Yeah.
that alarm will make, what do we do about that?
You call
Just
us.
call you guys.
Yeah, that's gonna be a call us, and like, you've got the helpline number, but my number is here also on the machine and on the control unit. Just call me, or you can call the cath lab and they'll call me, one of the two. Also, the CIC This normally is gonna be down towards the end of the bed, but you wanna make sure it's not covered with a blanket or a pillow, because it can get warm. This would cause the machine to overheat. This would be a case where the coolant wouldn't be titrated up. It's just uncover this, cool it down, and everything's gonna run and be happy again. So, but yeah, if it's a true temperature error as far as the catheter is concerned, it would be a situation where you're in like a heavily clotted vessel where there's little to no circulation, blood flow around it, and it can cause the ultrasound cord to overheat. So, and that's where it would be by 10 ml increments that the coolant would be titrated up.
And the coolant is always sodium?
Yeah, normal saline, yeah. 9 times out of 10 I say that, but we have had your rare occasions where a patient had to have something else. The reason why we always, majority of the time we use normal saline is because of the heat exposure to the ultrasound core. We don't want, the core can reach temperatures of 42 degrees Celsius, so 134, 35 degrees Fahrenheit. So anything that would be exposed to heat, any kind of medication or something like that, we don't want that.
What are some of the most common complications that you have seen most? Just the usual.
I mean, people kicking this off and these coming unplugged. Occasionally, we'll get it down. So, depending on where the catheter is, like if, say you're in a DVT, doctor doesn't normally know where the valves are, and sometimes, like if you reposition a patient, the tip of the catheter will go behind a valve, and these pumps are notorious for if there's any resistance on inflow, like if the tip of the catheter is blocked and this meets resistance, this will alarm with a downstream occlusion. So in those cases, ironically enough, if the patient's been repositioned, we put them back to where they were, and most of the time the catheter just rolls right back to where it should be. We might have you do a forward flush. If you do, it's normally with a 3 cc syringe, not a 10. This is going to be easier. The entire priming value for the drug lumen, all 3 lumens, is 0.8 ml. So super tiny. So when you go in with like this versus this, it's just going to be such a hard push. So it's easier with the 3. We don't use a 1 cc syringe. That's too much PSI, and we've actually had the lumens rupture. So that picture I showed you originally with the little, it looks almost like a clover leaf. So if you take this and cut it in half, that's what you're gonna see. And it's just super tiny.
Where are you doing the forward flush?
So your forward flush for the drug lumen would be here, for your coolant lumen would be here. So your
You were
coolant,
saying we never flush those because we might.
Suffer.
I mean, if, yeah,
Don't pull
yeah,
back.
you don't pull back. You do a forward flush, you just never pull back.
Okay.
So, yeah. And I mean, it would be at our instruction to tell you to do it, so. But that's it. Any other questions, concerns?
Do we have pamphlets? Because I feel like I'm not gonna remember anything.
I don't, but you have the QR code that you have links to, and we have all kinds of stuff right on the machine. it comes, like I said, with you guys here, it's gonna be more about the patient. Everything will be set up over in the cath lab. So you're gonna be on maintenance mode. It's gonna be taking care of the patient more so than anything else. If anything, their biggest complaint normally is my back hurts. So we put them into like a reverse Trendelenburg position to try and take the pressure off their back. Thank
How
you
long
so
does
much.
it typically run? Or it depends on the clot location?
Depends on the clot and the location, how much clot. PEs are normally around 6 hours, 4 to 6 hours we can do them in. But again, it depends on how much clot. There are some doctors that will run it a lower dose for longer if the clot is really extensive down in the lower lobes. DVTs, arterial clot, we normally see that run overnight. So, because that's something they want to let it run. There's got to be a reason as to why they're not just going in and sucking it out with a thrombectomy catheter. There's got to be more extensive clot.
Oh, so this is why you would use the EKOS.
Those are
Correct.
the reasons.
Correct.
Okay.
So I'm a toolbox girl in the PE world. You need a toolbox in order to treat PE appropriately. It's if you have a large central clot and can go in and pull it out, great. But there's a lot of subsegmental lower lobe clot also, and some of these patients are actually rethrombosing. But in those cases, that's where we shine, because you can use a low dose of TPA. Most of our TPA infusions for bilateral PEs are 8 to 12 milligrams. And that's the same or less than what they actually give in the labs sometimes. So it's very low dose, it's safe. As I mentioned, we're the most studied device in the PE world. And we've been doing it longer and safer than anybody else.
So if you have multiple tiny pots throughout the lobes, this is what you would want to use.
Yeah, you're not going to be able to go in with a 16 or a 24 French garden hose, whereas you could put a tiny 6 French catheter in, down into the lower lobe, do the infusion, and the long-term mortality rates are greatly improved versus some of the other devices out there on the market. But my doctors are always like, what do you recommend? And it's like, you do what's best for the patient. It's like, if you can go in and grab it, great. If you can use this, perfect. Do what's appropriate.
So once let's say the infusion are complete, is it just stopped or is it like titrated?
No, it's just stopped. So, like, I have docs that are doing a 2-hour infusion. It's 2 milligrams per hour per catheter for 2 hours. They're actually held in the pre-post area. Once the infusion is complete, they come in and they do an echo to see if the RV-LV ratio has normalized. If it has, they pull the infusions are stopped, ultrasound is stopped, catheters are pulled just like a swan. It's actually easier than a swan because there's no balloon to deflate. Lay them down, have them exhale, watch your monitor. Got 160 or 106 that you're pulling out total. So I always, whenever I pull, I always look at the tip, just make sure it's intact. And then the sheaths are normally pulled within half an hour to an hour. And then they go to just a monitor bed after that.
So that can be done at bedside, or we have to go back into
PE can be pulled at the bedside. DVT and arterial always is going to go back to the cath lab because there's a catalyst that forms the clot. There's always some reason, whether it be injury, stenosis, could be a fractured stent. Patients are in hypercoagulable state for multiple different reasons. Last week we had a patient that flew back from Europe, and travel's a big thing. Young females, oral contraceptives, that's a big thing. I always look at the patient history. I always find it very interesting to figure out what caused their clot to happen.
Is there any patient
So the question about for patients that we have to go to for ICU beds, and the therapy is completed, who is the designated person to remove the sheath? I know we're not trained to remove, so.
It might be somebody from cath lab that would probably come. So, either that or, I mean, depending on where they end up, because I know some of the ICU nurses are trained to pull sheaths, if I'm not mistaken. I know, I know at some facilities they are. Just like at South, the nurses are trained to pull the PE catheters on the floor. So,
Are there patients that would be ideal candidates for this?
any contraindication to lytics, that's your big, that's your big no-no.
Say that again.
Recent
Any
surgery.
contraindication to what?
Lytics,
Oh.
thrombolytics, so like recent surgery, that kind of scenario. Well, thank you, appreciate your time, and as I said, my number's on here, we've got the helpline, we've got the resources on the Boston website also.